Hello. All right, let's come to order. Call to order. 4 p.m. session. I'm going to just get us started here. If everyone would come on in, we've got a amazing panel for you, and I'm going to ask the panelists to come on up and take your seats. I'll join you in a moment. I'm Jay Wolgemuth. I'm the Chief Medical Officer, Quest Diagnostics. I've been on the board of the Personalized Medicine Coalition for several years and have seen something take shape that we're going to talk about today that has to do with the implementation of precision medicine, personalized medicine in large populations, and specifically in the employer setting. But before I do that, we're going to check our microphones and have our panelists just introduce themselves. Why don't we start on the end?
I'm Jane Gilbert. I'm Director of Retiree Healthcare for the Teachers Retirement System of Kentucky.
Hi, Scott McGill, President and CEO of Coriell Life Sciences.
Hi, I'm Michael Doney. I'm the Director of Medical Affairs at Color.
I'm Karen Knudsen. I'm the EVP of Oncology Services for Jefferson Health and the Director of the Sidney Kimmel Cancer Center at Jefferson.
Okay, and so we have a diverse group here today, and I just want to explain then what this topic is all about for a moment. I actually have been at Quest for 10 years, but I left after 5 on a sabbatical, and I came back. It wasn't really a sabbatical, but I say that, but I came back and then began to run our employee health plan, which is 60,000 members, and we're a self-insured employer. And I realized straight away that we pay for the health care for this population, and they're with us for 10 years on average. And I think we have very good judgment that there's a lot that can be done in a health plan like that to improve care and lower costs. And so we've driven a very aggressive program. And when you begin to look at it then from an employer perspective, and you take a look at the 2 fields that have emerged as really here and now in employer healthcare in precision medicine, that would be pharmacogenetic testing and cancer genetic testing. We now have an ability, we being an employer, have an ability to understand that I know what my pharmacy benefit is, I know what my population is. I can deliver a intervention to that population, and they're my population for the next 10 years, and I'm aligned on cost and quality and the need to engage them. And the motivation is really there to do some of the innovative work that we're going to talk about today. But also the data is there in that we have access to the claims data. We, not being the employer directly overseeing, of course, we have to be very careful about privacy and how the analysis is done. But we have been, through this mechanism, publishing data and adding to our understanding of how to implement precision medicine. And furthermore, when you hear the stories today that you'll hear, some of the implementation strategies that have been undertaken in that employer space are really helping to tackle some of the key barriers around making the information actually have an impact clinically. And we were just talking about it before we got started here, but the notion that a pharmacist can intervene to help a consumer understand what might need to be done with pharmacogenetic testing and also work with the physician office. Or that a population at Jefferson of employees can be engaged in a responsible way with genetic information and then supported into care and downstream relative to how that information can be used. So in both cases, we can achieve scale with genetic testing. So I'll start then with the cancer genetic testing, and maybe to tell the story on the color side and also at Jefferson what you did around implementation.
Great, thank you.
Yeah.
You want to start with color, and we'll
Great,
talk about
thanks. So just a little bit about Color. We are a health services technology company. We use or leverage a digital health platform to deliver health risk assessments to populations at scale. We work with health systems, enterprises, as we're discussing here, as well as large-scale research public health programs. Just a little bit about the process. I'll try to be brief. This digital platform is a very low-friction way to engage and enroll participants Along the way, we'll gather personal and family medical history. We combine this with the results of our genetic testing to deliver results back to participants via genetic counselors to their healthcare providers. I think of interest, and it's a little unique to the employer space, is with these health insights, we can then map or route individuals or participants to available health benefits, preventive health benefits which may be utilized by the or offered by the employer, and then we can deliver, if as desired, sort of aggregate population level statistics on the health risks that we are seeing in that population.
Yeah, so we had a great partnership that formed with Color a little more than a year ago that was a learning experience for us in our large academic health system. So for those of you who don't know Philly, Jefferson Health is the largest health system in that region. So we're a 16 hospital academic health center throughout a tri-state area. We are 33,000 employees. And one of the things that we elected to do in last year's benefits enrollment is to utilize this partnership with Color to offer color testing to all 33,000 of our employees. So from our perspective and my perspective as the head of all things cancer at Jefferson, this reduces the barrier to understanding genetic risk with a CLIA-based assay for cancer risk. There was also some pharmacogenomic testing and gene assessment for cardiovascular risk that was part of the gene panel that we talked about. We were really uncertain what the uptake would be from our employee population. It is the case that we knew we had employees already presenting in our own genetic risk clinic with ancestry testing, and from our concern, sometimes overinterpreting those data. I have a family history of breast and ovarian cancer, but it's okay, I took ancestry testing, and I don't have a BRCA alteration, so it's okay. So this is the kind of thing that we knew was happening in people's day-to-day life. And so we felt it incumbent upon us as a forward-thinking health system to make this something that all employees could have access to. So one was to remove the barrier to access. The second was to engage the employees in a way that they understood what was protected and what wasn't. We educated them about GINA law and about what would be done at the time that they got their testing. So when the employees ordered the testing, they were able to receive those privately, directly from Color, our honest third broker. And then they had two options. One was to come into our genetics clinic at Jefferson. The other was to call their Color genetic counselor and have that discussion, irrespective of risk. So it was just at this time when we had harmonized across our entire health system what our screening guidelines were for cancer, for patients both of average risk and patients of high risk. And so the way that this now works in this relationship is that if I call up Color, I did take the test, and I call up the Color genomics expert or genetic counselor and say, I'd like to discuss my results. They'd say to me, Dr. Knudsen, you are of the age where you should have had a mammogram in the last year. Have you had one? And if my answer is no, they offer to schedule for me into the Jefferson Health System. So for us, it's a way of not only providing that genetic information that we knew our employees were hungry for, but providing them a safe outlet to understand that information, and from my perspective as the head of cancer, to navigate patients to appropriate screening guidelines based on their genetic risk. So for us, it's really been a terrific relationship.
Karen, it raises so many interesting questions around, how this was done. I guess one point is that you, as a leader in cancer care, have a unique, very strong perspective on being able to interpret that information for the employees. But did you also then had genetic counseling access through Color? And did you, just out of interest, scientific interest, did you provide more than the kind of tier 1 recommended screening mutations that are in the guidelines because you know that there's more value there?
So it was really a partnership with Color. We initially started off with the idea of looking at a smaller panel of testing and thought, if we're going to do this, let's use the larger panel. We actually initially started off talking about only doing 2,000 employees. And then it occurred to us, what happens when you're employee 2001?
Yeah.
So in working with my president and CEO, Steve Klasko, We and our HR department, we found a way to make this work and offer it to all 33,000. I'm glad we did, because more than 1/3 have taken the color test just in the last year. So that 1/3 uptake was just staggering to all of us. Another lesson learned.
Yeah.
And in terms of selecting the panel, we wanted to give them the most accurate information that we could, that we felt that could be
It was
utilized.
actionable in some way.
Everything
right?
actionable. But it was also the case that we felt very strongly that we should protect the privacy of the genetic information of our employees. So especially as a healthcare company, this is very important to us. So I asked, and we all agreed with this at Jefferson, that even in aggregate, we will not learn the genetic information of my employee pool. I have no interest in knowing whether or not the BRCA alteration rate is higher in the Jefferson employee pool than in the general population. That does me no benefit. The immediate actionable benefit for us is what the employee learned to utilize in their own way, that they can share with their provider or not, but also the navigation to an appropriate screening program for cancer.
And that was the second part I wanted to follow up on, because it's going to be the same story on the pharmacogenetic side, is that it is part of the value is the genetic testing data, and part of it is that it creates an engagement for an employee around cancer risk screening and prevention. And you're bringing them, I think it's really true on both sides. There's an engagement tool here for cancer care and for medication use. And we see that the genetics is something people are very interested in. It provides value, but then you're taking it beyond that, steering them into care in the right way.
It's measurable, immediate value.
And we'll come back to that example. So now let's introduce the pharmacogenetics story. And maybe I'll start with Scott. You could just tell the high-level story of what you're doing there, and then get how it really worked with Jane.
Yeah. So we, like Color, are a precision medicine implementation company focused in the area of medication management. So that is effectively the combination of both genetic testing, pharmacogenomics, with more traditional forms of medication therapy management, looking at non-genetic risk factors like drug interactions, anticholinergic burden, Beers criteria, things like that, and providing a consultation service through that review back to the patient's own physician. So we all know that the healthcare system doesn't always get medications right. We know quite often it gets it very wrong. What we found through this program is actually 64% of the individuals who went through this program required an immediate change. So clearly there was a lot that needed to be worked on, and what we do is essentially empower pharmacy teams with tools, technologies, scientific testing, education, to be able to provide that service to populations of individuals. That starts with population health analytics work, where we can identify the hotspots of opportunity within a population through member engagement, education, enrollment, testing, analysis of that testing, and then ultimately the delivery of what we call a medication action plan to the patient's own physician. So what the physician is receiving is not a genetic test that they then have to figure out what it means. It's a very clear indication of they should not be on this drug, they should be on this one instead, and here's the reasons why. So this program was implemented starting right at the early stages of 2018 in the teachers' retirement systems of Kentucky. And Jane, if you want to kind of tee up what that population looks like and some of the unique challenges that we had there.
I had the opportunity and pleasure of administering a health plan for 36,000 Medicare-eligible retired teachers in Kentucky. I wanted to give you some background on the demographics so you better understand this population. Average age of 74. I've got 6,700 over the age of 80. We've got about 39 over the age of 100. The oldest is 109. The second oldest is 108.
Wow. Are they on any medications at all? Or?
One or two.
Unfortunately, they're on an average of 15 prescriptions, average for each of the 36,000. They're on an average of 15 prescriptions. I manage a Medicare Advantage plan that the retired teachers have been on since 2007. We also have a Medicare Part D drug plan, EGWP plan, that's been around since 2010. In regards to kind of our plan and kind of our role here, just some brief background. We had some very financially compelling reasons to contain costs within the state of Kentucky in regards to our health plan. So for retired teachers in Kentucky, the health plan is not a guaranteed benefit. So when the money's run out, the money's run out. So we have to be good stewards with a limited trust fund. And that's kind of how we embarked upon this plan of looking at those 15 prescription drugs, trying to make sure that if someone truly needs 15 drugs, that's fine, but we want to make sure that they need them, that they are working, all 15 are working and doing inside that their bodies what they are meant and supposed to be doing in that regard. And so, first and foremost, I'll mention that Teachers' Retirement System is a defined benefit pension plan. We cover 55,000 retired annuitants. Average age at retirement is 59. Average pension is $36,000 a year with no eligibility for Social Security for the retired teachers. I think no surprise to you, 78% female, 28% male. And again, my role is to make sure that we offer the most valuable health plan and drug plan that we can within the constraints, the revenue constraints of our medical insurance fund. So we embarked upon, as Scott mentioned, this program in early 2018. Some of the results that we have so far, so we invited all 36,000 of our retirees to participate. We have enrolled over 8,000 of those retirees into this program at this point in time. Kind of the good news is, as Scott mentioned, it resulted in 64% of drug recommended changes for that 8,000 that's participating. And 28% of that is directly related to drugged DNA. And I think an astounding 94% of the time, the doctors in Kentucky are accepting the recommendations based upon the genetic information.
Jane, I want to stop you there. So you just gave the 3 headlines, really big headlines here, okay, that are very meaningful. We should talk about them. 1, 94% or 96% of the time the physician, and physicians in Kentucky are like physicians everywhere. They're not easy to deal with. We've heard about that all day. Changing behavior, but it feels like it was seen in that case as a service has been rendered, there's been pharmacogenetic testing, and MTM with a pharmacist has occurred, and the pharmacist has talked to my patient and is now calling me and saying I should make the change. Okay, that's good information, thank you for the service. Can you describe that interaction on the 96%? Was it not all that positive, or, or Scott?
I can give some color there. So we also work with a group in Kentucky, a group of pharmacists called the Know Your RX Coalition. So our job, Corea Life Sciences, was to empower that team with bioinformatics clinical decision support tools, the science, and really enable them to perform this service. So when delivering this information back to the physician, I think key to this was a few different factors, key to the acceptance rate. One is the ultimate medication action plans are just dirt simple. There's no interpretation required. It is a very clear recommendation that this drug is wrong for this person.
And here's why.
This one is better,
Yeah.
and here's why. The other, I think, and I know there's probably a few doctors in the room, doctors do like to just be told what to do when it comes to medications. This is a very hard problem to assess what really should be the right medications for individuals. If you've now got a pharmacy service that has taken the time to review your patient in detail and has produced a report that says this is the wrong drug, this is the right drug, most doctors will simply accept it.
This is what I'm saying. It's a positive enabler.
Very much so, yeah. Most doctors are seeing this as a very value add to their practice because it's now
They believe
giving
in the
them.
quality of what is being done and
That's exactly
recommended. Agree with that. And then also that about 28% or a third, less than a third of the changes that occurred to the medications were due to the genetics. Now, that's and one way you could say, well, 30% of the time the genetics change the regimen,
Yeah.
But I like the other story, which is I got 60% change of I got 60% of the time I engaged a person in their 15 medicines. And by the way, most people don't need to be on 15 medicines. You know?
One would
Do
hope.
they, doctor? 15 medicines? No, you know what I'm saying?
It's a
So
lot.
I mean, it's an amazing
It's a lot.
statistic that the genetics got the person engaged, but then 65% of the time you're cleaning up the drug regimen.
Well, that's right, and I think there's a halo effect that occurs there as well. When you have a one-on-one consultation with a medical practitioner, a pharmacist who's willing to take the time to go through your plan, even if there are no changes, adherence goes up, because now you've been assured that you're on the pills that are actually intended to work for you. Where there are change recommendations, there is a subset that are driven by genetics, but the genetics, pharmacogenomics is not a silver bullet. It is not sufficient for actually making true decision support claims for medication management. You have to look at the comprehensive nature of medications and how they
In
interact
the
with
same
each other.
story, cancer genetics brings someone to the table
Got it.
around cancer prevention and care. And it's not the whole story at all. It's
Family history plus
Yeah.
genetics.
That's right.
And we should also mention that, there was pharmacogenetics in the panel that we also provided to
right.
our employees. So
the same type of model
it comes
applies.
back to them, but it's up to them to report that to their provider. So we have
So-
a less hands-on way of really enabling the employee
Mm-hmm.
in that case, other than what I would call very strong informational support to them based on the platform that Color uses to communicate.
Right. I wanted to ask a question for Jane and Karen about the employee response to the programs and how it was perceived. And you both come from an interesting place of coming from trust, that they have some level of trust that you're doing the right thing for them. But can you describe, Karen, why don't you start on the employee, how did they engage with it? How did they feel about the program?
Well, we were very uncertain, as I said, what the uptake would be. So the 1/3 uptake in 1 year's time with very little advertisement other than this appeared on your HR enrollment form and an email came to you and you clicked a button and you could order the test. So the enrollment
So a
uptake,
third-
a third exceeded our expectation.
Right.
And this is almost 11,000 employees have taken the test in
And now,
1
once
year.
you're in that group, you have a group that's engaged and interested, and then there's a variable experience within, but they must have seen it as a nice benefit.
They saw it as a nice benefit. They also had the option to enroll within Color for forward-thinking assessment. So, a variant of unknown significance today that may be meaningful a year from now, they could opt in from Color to be pinged about that. I think there were two things that really surprised me. One was I really anticipated the majority of questions to be about privacy and protection that we got back in. But that's actually not what it was. The number one question was, can my spouse take it too?
Yeah.
So that told us something that we could discuss with and we are discussing with our HR department this is a real need. We had a number of employees very vocally get their tests back, find out that, for example, there were a couple of employees who have gone public that were discovered to have Lynch syndrome. And then did cascade testing throughout their family and were very grateful, and it explains some of the family history that they previously had not really understood. So that was the first interesting question. It tells us that it's not just the employee, they want it for their family too, and they see value in that. The second was the demographic of who took the test. So as I mentioned, I don't want to know anything about the genetics of our employees, but I do want to know where are the gaps in this interest. And we're we're just over a 50% female employee base at Jefferson Health, but 83% of those that took the tests were were women, sorry. So the men really didn't show up to the table. The men should, that's why it's on my mind. But no, so it really surprised us actually how few men exercised this option through HR. So we're still trying to understand it. There's a research question in there on its own. And this is, for us, incredibly striking. We at Jefferson opened the first men's genetic risk clinic for prostate cancer in the country several years ago, and there are still very few. This is a very large point of pride for us. Prostate cancer is disproportionately high for incidence and mortality in our catchment area, taking out the density of the population. So this is something we really have prided ourselves on, of being very vocal about the importance of genetic testing if there's a family history, or if there's, for any man who presents with metastatic disease, we'll send them to our genetics risk clinic. So for us, as a healthcare organization, an academic healthcare organization where the men didn't show up to testing is still something we're trying to understand.
I'll talk to some men and
Please
and
do.
see, but they
I
tend
see a
not
few
to
guilty
engage in their own
stares happening in
healthcare.
this
Yeah.
audience.
But the model of having spouses involved in these plans, and also in the health and wellness space in general, being able to buy healthcare for my hubby, that I'm going to pay for a comprehensive genetic profiling for my hubby, is a real thing.
It's a
And the
thing.
men don't take care of themselves sometimes, right? So there's a taking care of each other thing there that is in your health plan you're exploring, it looks like.
There is.
And Jane, how did the retired teachers of Kentucky engage?
So we thought they would be more concerned with the privacy issues and why does a retirement system want to have my DNA tested? But to be honest with you, for 8,000 that enrolled out of 36,000, that's a pretty good percentage when you look at an average age of 74. And the fact that, again, we're the retirement system, not the employer, so they're spread, 89% of the 36,000 are spread all amongst Kentucky. And so I've been very, I guess, pleasantly surprised with the phone calls and the personal testimonies thanking us for offering this wellness benefit that would get rid of a trial and error method of prescribing and allow our retired teachers, many of them are, they're concerned about the 15 medications. Do I need to be on them? Are they helping me, or in fact, are they hurting me in many instances? So we have been very, very pleased with the response.
We feedback survey everyone after they go through the process, 3 weeks after, and we get some qualitative scores on how their perceptions of the actual process were, the value to them. But the thing that we really enjoy is we just leave an open text field for tell us your story. And the anecdotes we get back from the members are really, we use them in our weekly staff meetings just to make sure everybody really understands why we're doing this. So we have a different one that's read out every week. And it's things like, I feel like myself again for the first time in years. I had given up hope that I was going to find, a real solution here. So it's been great. It's been great.
Go ahead. Yeah.
Somewhat related, one of our partners that we work with are the Teamsters. So once again, distributed very broadly geographically, actually male skewed in this instance. And being able to surface those sort of aggregate level statistics about compliance with colonoscopy recommendations and things like that is actually pointed out tremendous gaps where as the Teamsters have been able to sort of focus their efforts in trying to improve compliance and improve the population
Yeah.
health.
No, I was making joke, being silly with it, but the engagement with healthcare services, with frontline employees, and also there's a different between men and women how they engage. But part of what I'm talking about is I think employers and employer plans are starting to realize we need to take a more active role in making sure our people actually engage with high-quality healthcare services. So that's kind of where I'm coming from on that. I'm going to give a little more follow-up on the pharmacogenetics just to tell the audience where it's going based on what you've done. And also I'm going to open it up for questions because this is a very ripe panel to be grilled with difficult questions about medical ethics and what have you. So I think there are microphones if you want to come up. So let me just tell you the finish, or the next phase on the pharmacogenetics is, based on what has been shown here and the way that I think that pharmacy services can make pharmacogenetics actually scale in a population. There are very large employers implementing pharmacogenetics now in the exact way that we described, which is employees are engaged. The employer can decide how deep into the population to provide the service. I could provide it to all 60,000 members, or I can select based on the analytics those that really might have the greatest benefit. Anyone on polypharmacy, anyone on a drug with an interaction that's known pharmacogenetically. And so you can tier that out and say, okay, well, I'll start with the highest value and go down. And then, yes, provide a pharmacy service that then helps integrate the knowledge and not only just takes the pharmacogenetic data, but fix the medications while you're there, please, right? Get that fixed up, and then have a communication back to the physician office on what the recommendation is. We hope your 96%, 94%, holds up, but, you can affect that level of change in 80 to 90% of the time. I'm really excited, as a health plan leader. A lot of other employers are feeling the same way, and at the same time, it helps you get at medication costs, which are one of the biggest line items, number one, and mental health and well-being, which is very hard to engage with in an employer setting, and it is now being engaged with in a pretty direct way through these pharmacogenetics programs, where a great deal of the value has to do with mental health prescription drug use. So that's going on. Thermo Fisher's a part of that, Quest Diagnostics, other employers launching based on your great model in 2020. So questions for the room, from the room? Go ahead.
Thank you. Steve Summit from the Wharton School at Penn. Jane, this is, I think, mostly directed at you. I'm curious about, do you have an age breakdown of the, I think you said 8,000 participants? Is it across the board, or do you see the younger retirees opting more so than the older, or is it the same throughout?
So we actually don't share that data in the same way that there's a wall with Jefferson and Color, very similar with Kentucky, but I can say that it tracks very well to just the average age distribution across the group as a whole. We have literally people who just retired all the way up to the upper echelons of the age pool.
All right, well that's very helpful to know. I'm almost disturbed that there isn't more concern about privacy issues, which leads me to believe in or wonder if the adequacy of your disclosure or the informed consent is adequate enough for people to really know what they're getting into. I say that not believing that confidentiality is a myth, but nevertheless, I wonder about that. And are they able to, while there isn't any personal risk, how do they assimilate the potential risks that you described?
And yeah, let's talk about each program, and the question is really what percentage engaged and actually participated, and then how did that consent process go? Karen, why don't you start?
Well, because we have experience with this with our own patient population of talking about what the risks are of genetic testing, we modeled that with our own employee population, discuss gene law and what it protects you from and what it doesn't. I would say I was, like you, surprised that there was not more concern about privacy and risk. But I would say that this is something that we know people are doing in their home personal life through ancestry testing. And so it may be that they've already familiarized themselves with the risk, or they're just willing to take that risk. One of the reasons that we offered it is because we felt that demand was already there in the employee pool, given that some of them were presenting at our own genetics clinic with ancestry testing that was not a clinical grade test. So I think that the general population in the U.S. is undergoing this transformation right now of weighing what is the cost benefit of understanding my genetics.
Okay, and I want to just take that point and agree completely that everyone out there has access to genetic data, and I can order a genetic test. I could pick it up off a shelf on my way to the airport. And so people have genetic data, and at some level, it starts to become, I have to provide high quality genetic data and interpretation. And I feel the same way at Quest that you feel at Jefferson around that point. At some point that I'm serving these populations, we need to have appropriate access to genetic counseling. We need to have an acceptance of that. So I think that's good. But I'd also say you had 70% that didn't participate. So they presumably, there's always a group there that will never touch this from a privacy standpoint. And then you described a very kind of straightforward, very academic consent process that sounds pretty rigorous. So how did you all consent people, and did you get anything, Jane, as far as, or Scott, feedback?
Sure. So we certainly heard that from some percentage of individuals that privacy and confidentiality was an issue for them, and some just simply said, I'm not going to participate because of that. I think what Jane and the retirement system have done very, very well is to set up trust relationships both to the retirement system itself and to the trusted partners of TRS. And so it really, I think, made a big difference that the program was introduced by TRS, not by Coriell Life Sciences. This was we are now offering this new benefit to you. We would encourage you to participate. Here's our trusted third-party partner, Coriell Life Sciences. And we spent a fair bit of time running focus groups to vet the communications so that the material was written at a level in which the common non-geneticist, the people not in this room, would understand. But we are dealing also with retired educators. So these are people that naturally have a curiosity and they want to learn and they're interested in new things. And I think that also played a role in the acceptance rate. But the confidentiality and privacy issues, once they were spelled out in the materials up front, so nobody had to go find it, it was something that we addressed right away, that has not been an impediment to enrollment.
And just to piggyback onto those comments as well, this is, we offer as a physician-ordered clinical grade test delivered within a clinical workflow, and there's opportunity for participants to speak with the genetic counselor beforehand if they wish, and of course all HIPAA compliant applies as well.
Yeah, I think it goes a long way in all of this to make sure that the consumer of it always has access to genetic counseling or a physician or a pharmacist if needed. So that's why a lot of us have gotten behind these programs, because they have access. If you don't have access, a lot of these things become major problems. You were going to say, Jane?
All of our materials, our invitations are tri-branded, so Scott mentioned kind of the trusting relationships that already exist between our retirees and the teachers' retirement system, but also that we had a medication therapy management relationship that already existed with those pharmacists with the Know Your Rx Coalition. So Coriell was the third and only new logo brought into this situation. We were very clear in our materials in terms of TRS would not have this information either in paper or digital form whatsoever. We have no need for it in that regards, that it would remain in a firewall there with Coriell. And again, the pharmacists have on-time, real-time access to Express Scripts, our pharmacy benefit manager, so they already have access to all of that information. The invitation itself came from the Chief Executive Officer for Teachers Retirement System, kind of to show again that we had executive buy-in as well as Board of Trustee buy-in.
And when we invite our Quest employees into the program, we have very similar messaging, and it's all about, and they trust us now that we've given them lots of different programs that, hey, we believe this is a high-quality program that will help you, and you can opt in or opt out. But we will not have any access to the data as an employer. However, in our program, we do intend to publish the results of the findings from implementation, and our employees consent to that it's part of our mission. Uh-oh, heavy hitter at the microphone, Daryl.
No, I'm going to pivot. I mean, with you just discussing some of the ethical issues that always come up in this conversation, so I'm going to pivot to an easier topic, the legal part of it.
Thanks.
Having been involved with the genetics non-discrimination law for a long, long time, one of the concerns about offering these programs through employer benefits is that there's a tacit inducement. By saying that you encourage your employees to do it, there's potential perception that if they do not, there may be some consequence from the employer. So how are you dealing with that perception and making sure that everything complies legally with the Genetics Non-Discrimination Act 2008?
I think it would be hard to look at the Jefferson model and suggest that there's inducement because we are so far firewalled away from those data. I think if there was a mechanism where we were using those data to change something about our self-insured product, then we would potentially be at risk. But it didn't feel like the right thing to do. We didn't do it. You mentioned only 1/3 had the uptake and the 66% didn't. It was really not very well advertised. It was simply just one of the things you ticked off on your HR enrollment and you got an email about it. So I think we were very careful not to walk this line about inducement.
Well, and it sounds like in your case, if you're very clear that a big emphasis is you have no access to the data, period,
This
on
is for the
opt-in,
employee only.
how can I use that in any way? Any other
I
thoughts
mean,
on this?
our program's completely voluntary. There was nothing mandatory about it. Teachers' retirement system, the medical trust fund is paying for the cost of the genetic testing. There's no inducement one way or the other. It was offered as part of a wellness program, so if you like silver sneakers, maybe you'd like to know if your medications are working for you.
Yeah, and in the implementation at Quest and with the employers, it's completely voluntary. If you opt in, we won't have access to the information on who's, doing it. And in the Quest program, we've introduced so many different population health programs the last few years. This is just another one, and there's some trust there that, hey, we're bringing it to you, take it or leave it, but it's really meant to be good care and to lower costs and improve quality. Another question?
Hi, I'm John Stigliano. I'm a Director of Precision Medicine in the Ministry of Health of British Columbia. I've got a lot of questions for all of you, but for the interest of time, I'll try and keep it short. Firstly, in terms of risk, I would argue, I'm also a geneticist by background, by the way. I would argue that patients don't really understand what risk is for what they're doing. There's a lot of risk, especially if there is absent or not good genetic non-discrimination laws. In future, patients can be compelled to share their data with a future health insurance company, which could impact their health insurance. Their children's health insurance can be impacted. Their grandchildren's health insurance could be impacted. This might change as policy changes, as budgets change, as stock market crashes, and pension funds have to reassess what they're doing. So there's a lot of things that need to be in place beyond just thinking, we firewalled ourselves and the patient is now, fine, we think. You need to future-proof what you're doing to ensure that future generations aren't going to be impacted by this information, because it's vertical, it's not just for the individual. I want to come to PGX now really quickly. The PGX studies listed on clinicaltrials.gov sort of peaked in 2010, and they've really collapsed. I think 2 are listed for 2019 of this, that have kicked off. So to hear that there's an 8,000 patient active implementation for PGX, I think that would be interesting data to get published and have payers assess to see if this is actually something that impacts outcomes.
That's very helpful. I want to say, though, payers don't determine what impacts outcomes. Payer policy is not a roadmap to effective health care. So I wouldn't point to that as the ultimate goal. But I also think that the data that is generated here and in these large cohorts is happening because we're able to scale pharmacogenetics in a population, and we weren't able to do that before through the clinical, through getting a cardiologist to order a Plavix test prior to a cath, and trying to integrate this into the current healthcare system has not worked. So I think the evidence generation is going to be great from this, right? And there's a lot of evidence being generated. I guess on the risks part, I think, it's a question of, how much risk people are willing to take to engage in their own health care and the value of that information. Those are some heady issues you're raising on that. Any panelists want to respond?
Just a couple comments on that. So we use a very targeted assay. There's not much there but pharmacogenomics, and so I think from a risk perspective,
On future generations and alleles?
Yeah, there's nothing there
information?
that an insurance company is going to reduce your coverage because you're a non-responder to Plavix. It's just
Because you're not finding, major genetic disease
correct.
categories.
Yeah, so
now.
these are very narrowly focused assays because these are commercial implementations. This is not, you won't see this on clinicaltrial.gov because these weren't clinical trials. These were commercial implementations in real-world populations. That's not to say that this data isn't incredibly valuable. We're working with a third-party consultant now to audit all of the data so that we can publish on this. We don't want anyone to have to take the word of a commercial entity that obviously has some interest in the outcomes as the truth here. And so we're going through that exercise now so that we can publish.
Thank you. Yes.
I mean, I think in terms to some of your concerns, I mean, we have a self-funded drug plan and a fully insured Medicare Advantage plan. The self-funded data is our data. I mean, if we were going to use that to prevent coverage in the future, we could already be doing that. It's protected by federal law. But again, we already have access to all prescription data. I mean, we could say, look, we're not going to cover someone who's taking this drug in the future. I just think what you talk about, it already exists in a self-funded health plan world where we're used to providing benefits and not using that information in any way that would prevent coverage in the future.
And I think in the programs we're describing, we're absolutely using the data for, in a responsible, positive way and steering people to the right genetic counseling, et cetera. So I feel very good about that. I think there's the question about the future generations and the data gets out of hands and now it's stuck with you. And, we got to keep working on privacy, and that's probably a legislative, question for the future. What is the guarantee that that won't happen? So, I'd like to say that was a good set of questions.
Agreed.
Go ahead.
Hello, I'm Stephen Wicks from the Colorado Center for Personalized Medicine. I wanted to talk a bit about the evidence for pharmacogenetics. So could you talk a bit about what level of evidence you're using, given the recent FDA crackdown on some companies?
This could be a 3-hour discussion, I think.
We'll make it quick.
We'll make it quick. So one thing we adhere very closely to is FDA guidance, so labeling guidance by the FDA on whether or not pharmacogenomic results for a particular drug are actionable or non. That we also use information from CPIC, from the Dutch Pharmacogenomic Working Consortium. There was a fantastic paper published by the Coriell Institute for Medical Research on how we actually score evidence for the both clinical utility and actionability of the pharmacogenomic results. But that said, there's, we focus on entirely those things that we believe to be actionable. But this is, because we're not testing single gene, single drug, these are comprehensive panels. What we're seeing is that the effect is very positive across the board in total, in sum. So it very well may be that there's more work to do on these drugs. We know that for sure, right? Most of these studies were done on Caucasian populations. I told you this could be a long one.
Yeah, no, it's a good one. Let me also round it out by saying
okay,
that,
good. You take it from
that
me.
the
Tag.
Yeah, no. The FDA also does not determine what the state of the science is relative to which mutations do have value in the population. But they do set standards around what should be reported and how it should be reported and how we should engage consumers. But I also think, Scott, that the model that you have established around providing a very thoughtful service, including a pharmacy consultation with MTM, is really puts it into a different place. It says we don't need to send a red, yellow, green report out to the consumer to try to make the action, right? We need to get the data and get people looking at it together with the physician and making a decision. So I think that really does address a lot of, it provides a really effective service, but does not fly in the face of what the FDA wants, which is, hey, you can't put out a report that has a labeled drug on it, where we haven't signed off on that, right? So I think it sort of works.
Yep.
Question?
Hi, Christine Formea, pharmacogenomics pharmacist from Intermountain Healthcare. And I have sort of a three-point question. First, we need some standardization across laboratories in terms of genetic variance reporting.
100% agree. Yeah.
That's a big, in terms of putting reports next to each other and being able to have the same report be meaningful for our patients wherever they are across the United States or across the world. The second thing is, in terms of putting that information into, that is standardized, putting it into an electronic medical record that is indeed useful for our clinicians, pharmacists. We had some great conversations about MTM pharmacists. But that is truly one of the areas where we greatly struggle, is putting that genetic information into the medical record to be able to preemptively help patients who are looking at genetic testing for wellness purposes, putting it in for accessibility and portability, and moving that into the future for when these patients need that information for medications that may come up later for later diagnoses. Huge need there. And in terms of MTM pharmacists, we're working on that in terms of the pharmacist workforce and retooling, retraining pharmacists who, like other clinicians, as we have previously heard, have not had that exposure and that education during their informative training years within the last 10 to 15, 20 years. But my question for all of you is, how do you see that we can leverage our unique relationships with our electronic medical record providers to be able to put these tools into place, to be able to put genomic indicators in to actually impact our patients' care? And I'd be interested to hear what each of your thoughts are on that. Thank you.
Let me take one part, and because you already spoke to it, it sounds like there does not exist a standardization of the pharmacogenetic alleles that we test. It sounds kind of somewhat easy to do.
Yeah.
Just to get that in place, but then it's how does the data talk to the EMR? And I know some things that are going on there, and I do think it's going to be, in the next year, there will be some standards around what will be the basic data to be printed to or brought to an EMR from the genetic testing. But it also then goes back into this whole question of people don't necessarily want all the alleles in the EMR. Is that right, Karen?
Exactly. I mean, the way that we've orchestrated ours is it's the employee's choice. You're empowering them with their own genetic information. Whether that goes into the EMR is up to them. And I think this touches on the risk and privacy piece. So at this time, in 2019, that's what we're comfortable doing. If one of our employees chooses to go to our genetic counseling program, it will be entered into the EMR. But if they choose to talk to the color genetic counselor, it's another level of which they can have a point of discussion, get more information, become further empowered, and then decide.
And it's very interesting to say, do you really want your data in the EMR? Do consumers have these fears that we were talking about earlier? And do I actually want it there? And will that be a problem for me? And, so it raises really interesting questions.
The level at which this information is useful in future prescribing is not at the allele level. Right? We don't want to flag a doctor and say this is a ultra-rapid metabolizer for CYP2C19, do something about it. We have to say, almost like drug allergy information, if you're trying to prescribe Plavix for this person, Plavix, they have a genetic allergy to that drug, and that should be...
You might want to put it in the pharmacy benefit.
Exactly.
Or
right?
at least have the flag.
Wherever that workflow exists, whether it's in the electronic ordering system from the pharmacy, the PBM, the electronic health record itself, wherever it's operational, that's where you have to focus getting that data. But it's at that level. It's not the raw genetic results, because then you're worrying about who's actually going to be reinterpreting that data on the fly.
And to layer that on with regard to cancer, it's not just the genetics. A BRCA alteration on its own is meaningless, right? So
it's almost,
the family
you don't want to
history
see it
has
out
to
of
come
context.
along with that.
Yeah.
So,
Great questions. Please.
Why isn't it the purview of pharmacy to obtain everybody's pharmacogenomics, I hate that word, match the patient before they compound anything? And I don't see why the patient has to pay or have his insurer pay for a panel. And the way I understand it, which is I'm not trained, is that if you do the full genome, you've got all those panels there. And if it's our data, I don't want to put my data in an EHR. I want an OMR, our own, on a dedicated cyber safe.
Right. Well, you're absolutely right on the whole genome. Ultimately, whole genome sequencing, as it gets cheaper and cheaper, does contain within it the pharmacogenetics, and ultimately we're moving toward larger and larger genomic assays. So that's very true. I think it would be great if a cheap option for pharmacogenetics was embedded in every pharmacy order, and maybe someday we'll get there, and part of it is the cost of sequencing, and part of it is having the informatics worked out, and part of it is having all the privacy issues worked out. But it's a good idea. It's a good idea. I think we're almost up on time. I told you this would be a killer panel. Very, very interesting. Raises a lot of interesting questions, but in my view is one space where genetics can be implemented at scale in the near term. And we're seeing how we're refining how it's being done. We're learning as we go to some extent. Very exciting for me as someone that's looked at pharmacogenetics. I told you 10 years ago we're working on it, trying to make it work, but it doesn't fit in a 1Z, 2Z genetic testing workflow. It's a much more of a population-based approach where you're able to scale it and bring the pharmacy services or the genetic counseling. So terrific job for our panelists for pioneering implementation in the space. Really great work. And thank you for a great panel. I appreciate it.
So we're coming up to the final session, and I want to introduce Cynthia Benz, the Senior Vice President for Public Policy at the Personalized Medicine Coalition, to introduce our final speaker. Cynthia.
Thank you, Ed. And I was really pleased when Ed told me that this would be my job at the conference this year. I know Daryl made a lot of comments earlier about standing in the way between you and lunch and then going directly after you. I think Dr. Gottlieb and I have the most difficult job being the people standing between you and the bar. But I have the distinct pleasure of introducing our final speaker today, Dr. Scott Gottlieb. Dr. Gottlieb isn't a stranger to many of us in the room, but for those of you who don't live and breathe regulatory and reimbursement policy, he's a resident fellow at the American Enterprise Institute. He returned there earlier this year after serving as the 23rd Commissioner of the Food and Drug Administration. During his time as FDA Commissioner, he fostered a reputation as a dedicated reformer with a record number of novel and generic approved drugs under his belt. There were 56 new indications approved for currently marketed agents, 35 new molecular entities approved, and biosimilars for the active treatment of cancer that came to market during this time. A landmark achievement during his time as commissioner was the introduction of the first commercial CAR T-cell therapy, and we heard a lot about that this morning. Newly approved agents for rare diseases and several pediatric cancers. It was truly an impressive period of growth, but particularly notable for personalized medicine. FDA blazed some new frontiers under his leadership in the personalized medicine space. We saw the first approvals of tissue-agnostic therapies, as well as a number of regulatory precedents on the diagnostic side to accelerate commercial diagnostics to help guide treatments to the right patients. In addition to these and many other noteworthy achievements, I'm actually going to bring up another milestone that he had the unfortunate pleasure of overseeing. It was the longest government shutdown in U.S. history, and he had to shepherd one of the most important federal agencies during that time. And you won't find it in his bio. I actually tried to look for something that we didn't already include in the program to highlight. He may not really care to remember this, but I raise it because it highlights the quality of person he is and why he continues to be an important leader. He accepted this difficult moment with grace, and his actions during the time of the shutdown reminded me of a quote from one of the books that I love most, When Things Fall Apart by Pema Chodron. And at 5 o'clock, the last thing you want to be hearing is quotes from a Buddhist nun, but I'm going to bring it up anyway. And I'd like to share it with you. She writes, "We don't set out to save the world. We set up to wonder how people are doing and to reflect on how our actions affect other people's hearts." Dr. Gottlieb openly expressed the personal toll that this took on him and his team, but he never failed to dedicate himself to supporting the FDA staff through the 35-day shutdown and upon their return to work. FDA continued its mission to protect and promote public health during the shutdown, and it's something that we should never forget and we should be continually thankful for. In March of 2019, Dr. Gottlieb announced that he'd be leaving his post after just under 2 years at the helm. The announcement came as a surprise and, frankly, I know a great disappointment to many of you in the community. But at AEI, he continues his work to improve public health through entrepreneurship and medical innovation, along with ideas to expand regulatory approaches that maintain patient and physician autonomy. Whether he consciously set out to save the world or not, Dr. Gottlieb continues to leave a positive mark on it and is a leading voice on policies we desperately need now to preserve incentives for research and innovation while still making care affordable for patients and for our healthcare system. We're really fortunate that he can be here with us this afternoon, and we all look forward to hearing his thoughts on what the policy landscape looks for personalized medicine. So please join me in welcoming him.
Thanks a lot. Thanks for having me here today. It's a real honor to be with this group. This has been a great group to work with when I was at the agency. I knew we were entering an era of personalized medicine when I had to send out a public health advisory warning people not to CRISPR themselves while I was FDA commissioner. I remember last time I was at FDA, I had to send out a public health advisory warning people not to use decorative contact lenses during Halloween, so times have really changed. I actually, on that approval of the first CAR T, so it was Kymriah, obviously. It was about my third month on the job. I've told this story before, so some of you might have heard it. I was briefing the president. I was in the Oval Office briefing him on drug pricing, and at the end of the briefing, they wanted me to tell him about the first gene therapy approval that we were going to do on the president's watch. It was about 2 weeks before the approval. So I briefed the president about it, and he was very enthused about it. And he always liked the stories about the technology that was being advanced on our watch over this time period, and was very optimistic about the life science technology that we were seeing come to market. And he was so excited about it. As I was walking out of the Oval Office, I had a pang of anxiety, worry that he was going to tweet about it. So I was in a meeting with Jared Kushner, and I had to ask his son-in-law to go back in and tell him he couldn't tweet about it because it was still commercial confidential. And I stood outside the Oval Office just making sure this interaction happened. I didn't know which was worse at this point, him tweeting about it 2 weeks before the approval, or me admonishing the president that he couldn't tweet about it. So I stood there and watched, and I saw the president go, I know. So I felt really good after seeing that. But that was my introduction to briefing him and the Kymriah approval. I thought I would talk about. I just want to talk briefly because I want to leave plenty of time for questions. Some of the things that we were thinking about on how to advance personalized medicine. And I want to talk across three different domains and just give some examples of the kinds of things that we tried to advance. First, thinking about how to create incentives and directional change in innovation in clinical trials to allow more personalized kinds of approaches to care to come to market. How to drive innovation, the kinds of data that's being collected that could be used to advance more personalized care. And then innovation in tools that can help inform more personalized delivery. On the clinical trial front, we recognize that a lot of the drugs that were being put into development were targeted towards genotypic features of disease and no longer the phenotypic features of disease. And the question was how to help those advances. And that's when you saw us try to advance paradigms like basket trials or tissue agnostic approvals, where we wanted to open up avenues for drug developers to put drugs into development that targeted the molecular features of disease and not just the phenotype. And this was most evident in oncology, where we made the first tissue agnostic approvals, and we put forward a framework for doing basket trials, where what we said was if you had a cancer drug that targeted some common molecular feature of cancer, instead of studying that cancer as lung cancer or pancreatic cancer or liver cancer, where the same molecular features drove the creation of tumors in different organ systems, we would allow studies on the basis of the ability to target the molecular feature, and you can enroll all the different kinds of tumor types in the context of the same clinical trial and get an approval across all the different tumor types across all different organ systems. And this was a way to enable sponsors with drugs targeted to rare mutations to get sufficient numbers of patients enrolled in a clinical trial to be able to show a statistically valid effect on a tumor and get basically a pan approval. A new way of thinking about how to do clinical development, and a paradigm that we're now seeing get adopted in other clinical contexts. This isn't just specific to oncology, but we're seeing people try to adopt the same approaches in other contexts. We advanced the concept of N of 1 trials, the idea that if you have a common backbone where you were just changing either a gene cassette or some molecular component of the drug, like an oligo, and you were just changing the gene sequence that it was targeting, could you extrapolate across the preclinical data that you had developed around the backbone and not have to replicate a whole preclinical tox package, but basically figure out a pathway where you could allow the approval of the drug almost as a service, where you were just tweaking it on an individualized basis for patients. And in fact, the FDA, the agency, is working on a guidance document to enable such a approach. And I had taken very few meetings. Actually, one of my regrets in the job was that I was so insular and took so few meetings. We were so concerned about the perception of showing favoritism to sponsors or individuals that we were very careful about the kinds of meetings that I scheduled on my calendar. But one of the very few meetings I took with a patient representative was with Timothy Wu, and the mom of the girl, Mila, that was profiled in the New York Times, because it was such a compelling illustration of the ability to try to advance this sort of N of one framework. And Janet Woodcock and others in CETA had a very, very strong desire to try to advance that kind of framework. And the other place we tried to create an approach that allowed more personalized care was our approach to, in my view, our approach to cell-based regenerative medicine, where when we came in, we recognized that there was a lot of what we felt was dangerous activity in the market. FDA had exercised enforcement discretion for a long period of time. The market had grown up to stem cell-based therapies, some of which were being used, in my view, in untoward ways without a lot of clinical evidence. So we felt we needed to start stepping in and take more aggressive enforcement action. At the same time, we wanted to open up a framework to allow investigators who were doing cell-based therapies on an individualized basis to have a route to the market, to have a way to come in and get FDA approval. And so at the same time that we stepped up our enforcement activity, in fact, the one place where I had sent federal marshals in to seize a product was in the context of a cell-based regenerative medicine. We took some pretty aggressive enforcement actions and went to federal court to sustain that action. At the same time that we did that, we advanced a guidance document that created a brand new framework where what we said was, if you're an individual academic investigator, and a lot of the people who are advancing cell-based therapies were individual investigators in institutions who couldn't possibly have the capacity or the resources to file a BLA with CBER, file a biologics license application. But what we said was, as long as you're following a common manufacturing protocol, we're going to allow different researchers to pool their data and file a common biologics license application, basically develop a consortia to file a license application, and we'll give individual site licenses to each individual investigator. So you as an investigator can literally hold a BLA as long as you're following common manufacturing protocol, even if you're using the stem cell therapies in slightly different ways. And this was a way to allow small investigators to pool together, even if they were trying to do things that were really personalized for patients in their individual institutions. And in fact, this framework, I think, can be used in other contexts, including the context of the N of 1 studies. So once you sort of develop a novel framework for regulation, it's something that can get adopted more broadly. And we did that in this case, and I think we're going to see this become a more common framework in other contexts. In fact, by the time I left the agency, we didn't know if this was going to work. We didn't know if people would actually come in and take us up on it. And by the time I left the agency, which wasn't that long ago, there were 3 or 4 different consortia that had formed for purposes of trying to pool their data to come in and get approval for stem cell approaches that they were doing within their own academic institutions. So it was working. We had people taking us up on the offer of this new approach. I talked about innovation in data as well and things we tried to do to advance that. And here there was a lot of effort to try to advance the use of practical clinical data and real-world evidence in clinical development. I think we're at a real inflection point in the agency's embrace of these kinds of constructs, and I think that the inflection point is going to be driven by the resources that we got for the agency to try to stand up a consolidated, basically a data set to do near real-time safety surveillance in the post-market using real-world evidence. If you think back to after some of the drug safety scrutiny more than a decade ago following Vioxx, Congress passed legislation that gave the agency resources to stand up what came to be known as the Sentinel Network, which was basically a consolidated data network, really, for the agency to access payer claims data as a way to do post-market drug safety surveillance. And that's become a very important tool for the agency. What we went out and did was we got $50 million added to the base of the agency's budget, which is actually a substantial amount of money for FDA in terms of a plus-up, to build out a consolidated database of electronic health record information. And we talked about consolidating 10 million lives of data. We're actually going to, the FDA is probably going to consolidate a lot more than that, to build out a consolidated database that the agency would use for post-market safety surveillance, near real-time post-market safety surveillance, and efficacy surveillance. And this was sort of a charge from Congress that came along with the money. I think this is going to supplant Sentinel in time, and why it's important and why I think it's going to create an inflection point at the agency is that now the agency has a mandate and has the resources to start developing methodologies for using real-world evidence to make its own drug safety and drug efficacy conclusions and insights. And so when you as sponsors, for the sponsors in the room, come in with real-world evidence that you want to use in the context of a registration trial or some kind of labeling negotiation, you're going to be interacting with an agency that is on its own working to validate these same methodologies. I think the whole sort of field of how to use real-world evidence to answer important regulatory questions is going to grow up very quickly. If you compare this to sort of modeling and simulation, it took the agency about 15 years from the sort of idea of using modeling and simulation as a component of drug review to really institutionalizing that in drug review. I remember when we created the office, the Modeling and Simulation Office, back in 2003 or 2004, basically the office consisted of Larry Lesko. Some of you will know Larry Lesko is one person. Now the office is 35 people, and I would say well more than 95% of all applications that get filed with the agency have significant components of modeling and simulation built in. The sort of migration of using real-world evidence in clinical development is happening much more quickly than that, and so I think that the adoption curve is going to be fast there. The other thing that we tried to do and we were working on was working on ways to standardize reviews, developing standard templates for drug review. I think this, too, is going to make the agency's ability to adopt different data constructs much more efficient. And what a standardized review, the idea of a standardized review is that instead of being an agency that collects applications from sponsors, what we wanted to do is have a standard template where what we would get from sponsors is raw data information, and that information would get dropped into this standardized template so that there'd be a consistent presentation of data as you went from review to review and division to division. So we would basically be moving the drug application process into a cloud-based environment. There would be a standardized application that reviewers would collaborate around, and instead of taking submissions from companies, we would take data from companies in a cloud-based way. I've just probably described Lotus Notes to all of you, and you're all sitting here, and you're like, we've been doing this for a long time. FDA hasn't. And one of the insights, and Janet was driving this vision, but one of the insights was I would have lunch with people who worked in the division or the ODE directors. One day I had lunch with a medical reviewer who told me that she had spent her whole day reformatting data that had come in the application into a presentation that she liked to look at data in terms of the charts that she liked to review the data. And so here was a medical reviewer with a medical degree doing the work that probably a data analyst could do much more efficiently and more effectively. Wasn't a good use of her time. We were better off having expert data analysts doing that work of standardizing the format and the presentation of information, having the medical reviewers do the work of applying judgment and interpreting that information. And so that's the O&D reform and the structural changes we were making in the review process were aimed at doing that, creating a much more structured approach, having experts in data analytics do the analytical work and the reformatting of data and the presentation of information, and having the people who had expert clinical judgment, applying that judgment and making informed decisions about it. Finally, I said I wanted to talk about innovation on the delivery side and what places, where were there opportunities to innovate in the tools we had available to try to make more personalized delivery of care. And the two other places that we really saw a lot of opportunity was one on the digital health side and two on the diagnostics. And on the diagnostics, when it came to FDA, the sort of a typical approach of the agency, and this isn't a pejorative statement at all, when you have a new field of technology, you want to try to fit your existing statute and your existing regulation onto that technology. And the reason why you want to do that when you're at the FDA is, number one, the rulemaking process takes a very long time. So if you have to promulgate new regs to try to regulate a new field of technology, you know from soup to nuts, the average rule takes 2.5 years, and a complicated one could take 3 or 4 years. And if you have to go to Congress and seek new statute, you don't know what you're going to get. So you're sometimes reluctant as a regulator to open up that discussion. On the area of laboratory-developed tests and diagnostics, the agency had struggled for a very long period of time trying to fit the medical device paradigm to diagnostic tests. And what I said when I came in was that I would, in earnest, work to get a legislative solution. But we would agree that we weren't going to try to regulate laboratory-developed tests using guidance and trying to fit the medical device paradigm to laboratory-developed tests in places where we didn't think of fit, outside of a certain subset of cases where we had very acute public health concerns and we needed to take regulatory action to protect consumers and protect patients. And in fact, we went down that path. We worked closely with Congress. We passed back to Congress 70 pages of technical assistance to support the development of that IVCT legislation, which became the VALID Act and has been introduced on a bipartisan basis, which I think is going to pass. When I say 70 pages of technical assistance, people from Washington should probably smirk because 70 pages of technical assistance sounds awfully like a draft bill. We worked very closely on that to get that to get that bill right and try to get a framework in place that was uniquely adapted to laboratory-developed tests. And in fact, we took it out of the traditional medical device paradigm and created a new paradigm that we called in vitro clinical tests that borrowed from the medical device paradigm but didn't treat laboratory-developed tests and diagnostic tests more generally as medical devices per se, but we created a separate framework. On digital health, you know, we really, I think one of the things that surprised me a little bit was the pace at which we saw those tools coming to market. I thought that there'd be much more rapid adoption of digital health tools in the context of delivering drugs as sort of drug service delivery systems. And I thought pharma would be making more rapid investments in digital health tools and promulgating them alongside drugs. One of the things that we did to try to facilitate that was we moved the regulation of a lot of digital health tools that were promulgated in the context of drug approvals to the promotional labeling rather than the product labeling. And by doing that, we subjected them to post-market enforcement, basically post-market regulation. Because if the digital health tool was part of the drug label, it would have been subject to pre-market approval requirements. By putting the digital health tool into the promotional labeling of the drug product, it was subject to post-market regulation. And depending on the claims you're making, I mean, if you're making treatment claims with a digital health tool, you're going to be regulated as a medical product. But there's plenty of green pastures and area for people to promulgate digital health tools that can help with compliance, help collect information, help inform patients about the drugs they're taking, and allow them to be more active participants in their care, where you're not making outcomes claims and you can promulgate that digital health tool alongside a drug and probably, I think, affect a better goal for the patient. So I think that that represents an area of a lot of opportunity. My belief is that companies are going to realize, you know, over time how to make wider use of digital health tools as a way to develop a better relationship with both the providers and the patients in an environment right now where it's very hard for drug companies to have a relationship with providers and patients because it's so tightly regulated. And a lot of the traditional avenues for communication are closed off, including promotional avenues. So those were some of the opportunities we saw. I think looking out on the landscape, I think some of the biggest challenges we face are on the coverage side and just making sure that these opportunities are accessible to patients. I was in Washington today and did a luncheon for some members of Congress, and you know, the sense of concern around the challenges with access and the perception that pricing is playing a prominent role in foreclosing access for a lot of patients who need these therapeutics is really palpable. And the mood, I think, has changed a lot on Capitol Hill. And so the environment's ripe for something to get done, probably not before the next election in my view, but something will get done. And I think we're at a sort of, not a perilous point, but a fragile period of time right now where if we don't make the right decisions of what we do in policy to try to make sure more people have access to these opportunities, and these opportunities are democratized, and your ability to access a curative treatment or a gene therapy isn't dependent on what insurance pool you're born into. If we don't make the right decisions about how we enable those opportunities, some of these opportunities can be foreclosed, because what's going to get lost if we make the wrong decisions in policy, I'll just close here, isn't necessarily we'll have 5 to 18 fewer or 8 to 15 fewer drugs, as the CBO said in response to the speaker's bill. I think what's going to get lost is the risk taking. If we raise the cost of capital in this sector and we start regulating the returns, you're not going to see companies get out of developing drugs. You'll see companies start to take less risk and start to make different kinds of bets, and the nature of the innovation that takes place could change. You still might get the same number of drugs, but you'll get different drugs. And in a time when we all believe, I think, that the life science field is really the opportunity of the century that we're in to really transform human health, it would be a shame to see a lot of the really big bets that we've been making on science in recent years when it comes to gene editing, gene therapy, cell-based regenerative medicine, and all the things that we probably can't even envision right now get foreclosed because we've made policy decisions that sapped some of the risk-taking that has enabled these opportunities to come forward. So with that, I left 25 minutes for questions. I'm looking forward to it. I know this is a very good group, so thanks for having me here today.
Hi, Scott. It's Natasha Loder here from The Economist. Talking about drug pricing and less risk, I mean, one of the lessons I'm hearing from the biotech companies I'm talking to is that there is less risk, and the drugs that they're creating are targeted. They know the molecular target, they know the population, the patients, they can select them. They're talking about drugs that can be developed in 5 years, not 10 years. They're talking about 400 million per drug, not 1 to 2 billion. So perhaps actually there is less risk that's being taken, and perhaps the model that the pharmaceutical firms have been telling us actually isn't the one that's actually on the ground if you go and talk to biotech companies around here. So maybe actually what we do need is more pressure on pricing, because that will favour more personalised drugs. And so that's up for discussion.
Yeah, well, I think we're going to get more pressure on pricing, so I think that's an inevitability. You know, I think the risk that I see, the risk-taking that I see is on the very novel platforms. I think when you're talking about, you know, using novel systems for gene editing or very novel approaches to regenerative medicine, those are unproven platforms, and so that takes a high degree of capital investment and a high degree of uncertainty. And you know, when you're sitting here looking at these programs, and from a venture capital standpoint, and I obviously work with a venture capital firm now, and you're risk adjusting these models, and many of you in this room do the same thing. You're going to risk adjust a very novel platform where it's unproven, the regulatory pathway is unproven, differently than you would risk adjust a small molecule targeting, you know, biology that's well understood. And so that's where you see a change in the risk-taking behavior. If your cost of capital goes up, and your cost of capital would go up under some of these policy constructs, and your returns get capped, and your returns would get capped under some of these policy constructs, in order to get over the hurdle rate, you're going to have to adjust your model in some way. And the one place that you can adjust a model in that scenario is to try to lower your risk. So you're going to look for ways to de-risk the development program or look for less risky things to invest in. I think that's the risk of some of these constructs. And look, we might be willing to make that trade-off. When we designed, and I was around when we did it, when we designed Part D, part of the reason why we reinsured all the specialty drug spend in Part D, the biggest reason we did is because we wanted to make sure premiums were low at the time of launch of those Part D plans. So we felt by reinsuring the specialty drugs and taking it off of the plans, premiums would come in lower, and in fact they did that. But part of the thinking was that by reinsuring the category of specialty drugs, we would shift incentives towards the development of specialty drugs. This was over a time period when the common refrain was everyone's developing Me Too products, everyone wants the 10th statins, nobody's innovating. Drug companies are investing in, you know, OTC drugs and animal health and generics, and they're not investing their capital in high-risk endeavors that could potentially cure disease. And so we tried to design a structure in Part D that would drive investment towards higher risk specialty drugs. I'm not saying that's the only reason that the complexion of the industry has changed, but I think it's one of the reasons. We made deliberate policy decisions to try to drive investment towards unmet medical needs and make it very competitive if you were sort of if you were in a market where there was good enough generics. That was going to be hard to compete in. So you saw companies get out of primary care indications and go towards specialty indications in, you know, basically in an overwhelming way. So if we want to make policy decisions that drive investment back towards different kinds of development, we can do that. We should have a strong public health rationale for why we're doing it, and we should understand that we're doing it.
Hi, Scott. I'm Nina Hill with Pfizer. I hope it's okay to ask this question. And thank you for all that you did to help us address unmet needs. We understand that 21st Century Cures 2.0 may be afoot, and that representatives are doing a listening tour. What would you like to see if there's such a vehicle in order to advance both precision medicine and digital health and other innovations?
That's an interesting question. I mean, I think if we try to do something, we had a meeting this morning actually with Mark McClellan at the Duke Margolis Center talking about how to create different kinds of efficiencies in the coverage process with CMS, so that when you had new innovation, very novel innovation, there was a more predictable process for coverage under Medicare. And I think that if we do a sort of Cures 2.0, we ought to think about how to innovate and create more predictability in the coverage process as well. You know, one of the things that I've observed is that a lot of the sort of definitions that Congress has attached around some of these pathways that is created in the regulatory process, whether it's things targeted to the development of anti-infectives for multi-drug resistant organisms, or even the breakthrough pathway, the language that Congress uses to describe why it's trying to create incentives in the development process to make the regulatory process more efficient go beyond just safety and efficacy. There is an expression of value delivered to consumers, and so to the extent that the language is starting to more closely resemble the kind of legal threshold and determination that CMS has to make to make sure something's reasonable and necessary for the Medicare population, I think that there's places where you could say that if FDA gives makes a certain determination that a product is eligible for a certain expedited pathway, that meets the regulatory burden for being reasonable and necessary, and it could be a presumption of coverage. And so I think that you can get more alignment between the regulatory and the coverage process that way. CMS will balk because they'll say that it takes away some of their discretion, but you don't have to say CMS has to cover it a certain way. You just just say there has to be some base level of coverage, maybe with coverage with evidence development, and by doing that for both medical devices and maybe certain categories of drugs, by creating a presumption of coverage, you lower the cost of capital. That becomes a ticket that makes it easier to raise capital for the development of that product because you know there's going to be some base level of coverage. So I think thinking about how to do that in a sort of Cures 2.0 and thinking beyond just a regulatory process. The other thing I would say is that we've made a lot of accommodations in the regulatory process to get breakthrough drugs or drugs that we think are transformative to the market more efficiently. And what we're seeing is that in a lot of these categories of drugs targeted to unmet medical needs, the second to market innovation isn't coming to market anymore. Part of that, I think, is a function of that when you have a drug that's targeting a small population, being second to market is sometimes very hard. You can't sustain second to market innovation in a small population where the prevalence population has already been treated, and you're just going to split the incidence population. The incidence population, the number of people diagnosed with a disease each year, might not be enough to sustain second-to-market innovation. The other challenge is that it's hard to enroll the registration trials if it's a truly unmet medical need and there's first-to-market innovation. It's going to be hard to find people to enroll in a study, especially if you want to do a placebo-controlled trial. Nobody's going to enroll in that. You're going to have to look to do it ex-US. That might not be ethical. And so I think we need to think about how to create incentives in these unmet medical, in these categories where you're targeting unmet medical needs, not just for first-to-market innovation, but also second-to-market innovation. One, it creates competition that facilitates access, and two, the therapeutic differentiation is important. If it's truly an area of significant unmet medical need, you know some people aren't going to respond to one molecule, they might respond to another. You want some therapeutic differentiation. We actually studied this systematically, and it's very apparent that the time it takes to get second-to-market innovation to the market has been extended, and more of these categories remain monopolies in perpetuity. We had the data. We studied it. We had the data. It was submitted to a journal. It should have been published. I don't know where it is. It should be coming out soon. I think they held on to it until I left, so I couldn't get my name on it.
Oh, okay. Well, thank you very much.
Hi, Scott. Darrell Pritchard with the Personalized Medicine Coalition. I really appreciate that you brought up the effect of the drug pricing push on innovation. And I was hoping you would make some comments about the potential for third-party value assessment frameworks to be used to sort of dictate pricing or to be used to influence payers, including CMS, on the pricing thing and how that can affect innovation.
Yeah, well, I think there's probably an inevitability to this in this country, and when you're having a discussion about importing OECD pricing into both Part B and Part D, I think that if that comes to pass, or some element of that comes to pass, I think a lot of people who are involved in these endeavors are going to say, you know what, I'd prefer a US-style HTA process that makes assessments based on our values and our systems as opposed to just merely importing the results of European HTA processes, i.e. OECD pricing. So I think that is going to compel us to think more broadly about what we do here. Now, if we do end up with some kind of HTA framework in this country, I think it's going to be, uniquely American. It's probably not going to be one entity like you have in the UK where you have NICE. It, hopefully would be multiple entities that might compete to try to do assessments, and you'd have to, price a product relative to one of them or some aggregation of them, and it'd have to be within a certain benchmark of what they're coming up with. Sort of similar to the way we've developed compendia processes in Medicare Part B to make determinations that coverage is tied to when it comes to oncology products in Part B, where we sort of outsource some of that to expert opinion that has to operate under certain rules and certain regulations. I think that's probably what an HTA process would look like here in the U.S. But I do think we're probably a political cycle away from that kind of a reckoning, especially if you start seeing proposals go forward to tie pricing to OECD prices in either Medicare Part B, or there's some speculation they might try to do it in Medicare Part D. I don't know that these frameworks are going to be easy to implement. They might not be workable, but the fact that we're having this discussion and regulation seems to be going forward, it represents a real turning point, I think, in the mood in Washington and what's possible right now in this environment.
Ryan Cross from Chemical and Engineering News. I've been covering the N of 1 therapy movement, and so my question is, what happens when we have dozens or hundreds of groups trying to do these N of 1 therapies? What happens when we have biotech companies trying to do N of 1 therapies? And where do we draw the line between N of 1 versus N of a few or N of 10?
Well, I didn't know there's press in the room. I guess it's just not off the record. No, I'm kidding. It's an interesting question what the business model is here. I'm not sure that there's an easy business model, because if you think about what people are doing right now with the oligos, it's not very novel technology, and so it's not clear that you're going to be able to protect the underlying technology. You probably can't protect the process. And it's exceedingly expensive. I mean, the cost of goods, especially if you have to do a full preclinical tox package, which I don't think you'd have to do in time, but even a little bit of toxicology, you're talking about hundreds of thousands of dollars for cost of goods related to just a single N of 1 therapy right now, even with a well-established framework like an oligo, if you look at what Timothy Wu's doing and some of the others. So I'm not sure what the business model is here, whether or not this is something that can be done in a for-profit way, or whether or not it has to be done in sort of a charitable way with some foundation support, maybe by institutions, supported by philanthropy. And I also don't know that the market can sustain too many of these. I think there's going to be some consortiums probably that come together, some academic institutions that come together to try to create these kinds of frameworks. But I'm not sure the market's going to be flooded with dozens and dozens of different approaches here because of the challenges of doing this on a commercial scale. From a regulatory standpoint, if I had to look in a crystal ball and guess what's going to happen, I think what's likely to happen is that you have a backbone that's well understood, like an oligo, FDA, and you have, sort of a suite of diseases, 60, 70 diseases, where you literally have a dozen patients with each disease, maybe even less than that. FDA requires you to study 3 different diseases, and once you can demonstrate clinical efficacy and safety or a favorable profile, then it allows you to extrapolate to diseases that have sort of similar characteristics in terms of not necessarily the phenotype, but the genotypic features of the disease itself, where the biology can create a presumption that if it works in one setting, it's likely to work in these other settings. And so after that, you can extrapolate to other adjacent disease entities. And it's somewhat similar to what the FDA has done in certain contexts where there's been diseases where there's slightly different genetic variants from patient to patient, but they've given approval across all the genetic variants for a drug that seems to target all the genetic variants, but they didn't require a study in each individual genetic variant. And sometimes the FDA has contemplated approvals for broad indications if you can study the underlying features of the indication in a couple of different settings. And so one example, it's a bad example, but it's an example, is Modafinil, where Cephalon tried to seek an approval for Modafinil as an alertness pill. Modafinil is sort of the go pill that pilots use to stay awake on like 30-hour bombing runs. And so the company studied it in 3 different settings where alertness was a feature. One was sleep shift work disorder, sleep work disorders, where you had shift work at night, where you were up at night, and then you had to sleep during the day. And there were 2 others. Ultimately, FDA didn't grant them the broad indication. They studied all 3, and they demonstrated efficacy. I think FDA didn't grant them the indication for a variety of reasons. I wasn't there at the time. I think one was concerned on the AdCom that it would become sort of a lifestyle pill. But that's an example of the regulatory construct of allowing the sponsor to study something in multiple settings and then extrapolating beyond that. So I think that's probably the construct that you end up coming to. Now, I'm not sure where the agency is. I didn't look in on the guidance before I left, so I don't know where the thinking was on this. This is just my speculation.
Hi, Jen Mahoney from Asuragen. I'm going to start my question with my belief, which is precision diagnostics is really critical for precision medicine. So in order to have robust and safe diagnostics, the IVD path is great. However, it does not enjoy the same protection as new drug approval, where FDA provides exclusivity. So, even if you go through the rigor of IVD approval, you are facing LDT in the field. So my question is, what do you think FDA can do to provide more protection to IVD manufacturers to encourage more risk-taking?
Well, I mean, FDA doesn't really confer exclusivity. There's certain places where FDA confers exclusivity. Most drugs are protected by different patents, use patents, and composition of matter patents. In places where FDA confers exclusivity, you get 3 to 5 years of Hatch-Waxman exclusivity for an NME. You can get orphan drug exclusivity. So there are places where Congress confers additional exclusivity and data protection when a drug, meets certain sort of public health imperatives. On the diagnostic side, I think the issue, in my view at least, isn't necessarily that you can't patent the underlying technology. The issue has been that you can innovate around the diagnostics very easily. And so even if you have exclusivity on something that you're doing that's unique, there's a lot of ability to innovate around any one person's technology. So that's been the bigger challenge. I'm not sure how you get around that. You can create a process where if a diagnostic is meeting some important public health consideration, maybe you confer some kind of data exclusivity, but I'm not sure that there's a real appetite in this environment for creating additional exclusivity for technology right now. Frankly, I think the momentum is in the other direction, trying to take away patents and exclusivity, not grant them. So that's a difficult discussion to be having right now.
Hi, Burns Blacksall, Christ Hospital Health Network in Cincinnati. And first of all, kudos for what you were able to accomplish in your time at the FDA. So I have a lot of questions. Some of them surround, like, should we be approving oncology drugs that prolong life for 1 to 2 weeks? But that's a separate discussion.
Happy to answer that one.
So, but my simple question is, the FDA recently released kind of tighter guidelines on pharmacogenomics. So there are tighter guidelines, but we do know that there is an impact to be had with doing pharmacogenomic profiling and prescribing. So how does the FDA or other agencies advocate for us to actually be covering those tests? Because we do know that there is an impact when they're utilized.
Yeah, well, so this was one of the places where I made the comment that we agreed that we weren't going to try to assert oversight over laboratory LDTs, tests that were being promulgated as LDTs, except for cases where we had, really clear public health concerns. And this was a case where we had clear public health concerns, and I was there for a good portion of this. We did everything we could. We initially put out a public health advisory relating our concerns. We communicated with sponsors. Finally, the agency issued a warning letter. So, that was driven by a view, among other things, that there was variable quality in terms of the pharmacogenomic tests that were being promulgated as LDTs, or there might have been variable quality. I won't make an assertion that there was. And people were making important clinical decisions about dosing drugs on the basis of tests that weren't being subject to a consistent standard for clinical validity. And so there was a public health concern here that was raised by some of the drug officials. And one of the things that I said when we made an agreement between all of us, and everyone was invested in this, and everyone felt good about what we were doing, that we would try to pursue legislation and hold off on trying to do things through guidance that could ultimately get in the way of legislation, because if there was a perception that we were able to partially address this problem through guidance, Congress is less likely to act. And so we wanted to get Congress to act. We wanted to have a framework, a proper framework created. But one of the agreements that we all had and all felt strongly about was that if we had a public health concern, we were going to take action in that area. And this was one of the places where we had a public health concern. So, one solution is to come in for FDA approval with a pharmacogenomic test. Another is going to be that I think a lot of these tests will have an easier path for validation once that regulatory framework is created, the IVCT framework, where FDA is going to grandfather in a lot of the tests and take a firm-based approach to the regulation of a lot of these tests and allow firms to go to market with tests and go to market with adaptations to their tests as long as they follow good SOPs. And so I think that there's a vision for how there can be a more efficient path to market for FDA-approved tests in this context.
Great, thank you.
Mark Adan from Illumina. We were really thrilled to see all of the innovation at the FDA and the parallel review process with the CMS. In your current role, when you think about the commercial payers in the U.S. and risk adjusting your models, what advice do you have for them? Because we do not see the same progression as we have seen with CMS and FDA.
Same progression, because I would think that, you mean in terms of like a parallel review type of process? I mean, it's an interesting question. I don't see the same challenges with some of the commercial payers. I guess, there are situations where commercial payers are slow to adopt new technology or cover new technology, but the difference with the commercial payers and CMS, in my view at least, is, and we used to say this when we were at CMS isn't an ordinary payer. CMS makes binary decisions, and when they make a decision around a technology, it ends up driving the entire market. And so I think CMS needs to take a different sort of view around coverage than a commercial payer is free to do, because CMS ends up having such a disproportionate impact on whether or not the entire country is going to get access to a new technology. And that requires CMS, I think, to be more accommodative, more judicious, more flexible in how it approaches coverage, because CMS isn't setting the ceiling, it isn't setting the floor, it's setting the ceiling. Like there won't be coverage beyond what CMS determines, because everyone in the private market is going to follow CMS's coverage rules for the most part. And so that's why I think thinking about how CMS embraces new technology becomes very important, because it ends up having such a disproportionate impact on the market.
Thank you, Scott, especially for your candor. It's quite refreshing. I'm Steve Samet from the Wharton School, UPenn. We've heard a lot today about the internationalization of precision medicine, not only Europe, but China as well. Can you share with us any thoughts about the pace, direction, and possible conclusion of where we might go with international harmonization of regulation?
So I worked closely with the Europeans when I was there. We got in place frameworks for recognition of sort of joint regulatory principles, certainly on the manufacturing side, where we had mutual recognition of European oversight of manufacturing facilities, so we wouldn't be dually inspecting facilities. But you also saw the agency promulgate a number of joint documents around what the appropriate review standards would be for products, particularly in areas of unmet medical needs. So we put out that paper on the regulation of MPS diseases with EMA, where we sort of outlined what the clinical requirements would be for the pre-market review of drugs targeted to some of the MPS diseases that hadn't been drugged yet. And that was out of a recognition that with a lot of these rare diseases, there's a very small subset of patients globally, and if we're not all aligned on what the clinical trial should look like and don't allow an easy path towards the towards the enrollment of a global clinical trial, you're not going to get innovation in some of these areas of extreme unmet medical need. I will say with the, my Chinese counterparts, and I met with them, it was a little bit more difficult because I think that the Chinese regulatory system was adopting a lot of policies that were non-tariff trade barriers. I think that there was a different approach being taken to what they were doing in their regulation, and so far as they were looking towards regulation, and maybe what the regulators weren't doing this, but the policymakers who were instructing the regulators were, but to the extent that there were aspects of what they were doing in their regulation that were designed to try to create barriers to entry for ex-Chinese technology or to protect incumbents in China, I'm not going to harmonize to that. And so, that made it a little bit more of a difficult discussion with the Chinese regulatory counterparts. Am I up on time? Last question? Oh, I'm out of time. Drinks. No, I'm sorry.
With the decreasing pricing and a dynamic range of next-generation sequencing, theoretically, I think we're going to start to see, probably in maybe less than a decade, the ability for a lab to maybe diagnose almost anything. Is the FDA prepared to use the full dynamic range of maybe next-generation sequencing in the future? Thank you.
Yeah, I think so. If you look at what we did with AI tools and next-generation sequencing, we tried to take a novel approach, I think, to how we regulate these products, recognizing the traditional regulatory paradigm didn't fit. And so what we said was, if you can demonstrate clinical validity against an external data set that's a validated data set, that would be sufficient for regulatory purposes. And we actually recognize the NIH data set as their genomic data set as a data set that can be used to validate next generation sequencing platforms, because we recognized we couldn't rip apart the platform itself, just like we couldn't rip apart an AI tool. We had to rely on the results that the tool was generating against a standardized data set and use that for regulatory purposes. I think one demonstration of this was when we approved the EKG app on the Apple Watch. Why that was very novel was everyone expected FDA to rip apart the watch and make sure that the watch was working. And what we said when we approved that was, we're going to ignore the watch and we're going to just look at the output of the software tool itself that sits on top of the watch. And as long as we can validate the results that it's generating, that would be sufficient for approving that. And so the same kind of concept we took with respect to the next generation sequencing platforms and AI medical devices as well. Thanks a lot. Thanks for the opportunity to be here tonight.
So we've come to the end of a long and productive day, and I invite you now to join us at the Isabella Stewart Gardner Museum. There are buses waiting for us outside the front door that'll take us a very short distance to the museum. I hope you'll join us, so thank you.